Hi, this is Bucky Stanton, and on this episode of Technology Stories, I talk with Nancy D. Campbell, professor in the Department of Science and Technology Studies at Rensselaer Polytechnic Institute, and author of Using Women, Gender, Drug Policy, and Social Justice, and also author of Discovering Addiction, the Science and Politics of Substance Abuse Research, and author of the recently released OD, Naloxone, and the Politics of Overdose. Thank you so much, Nancy, for coming in and talking with me on Technology Stories. I wanted to bring you in because there's been this emerging conversation in the COVID-19 pandemic about what is essential and what is not. And substances have become a really interesting part of that conversation. For example, there's been a lot of controversy in New York State about keeping liquor stores open as essential businesses. And recently there's been a lot of discussion about the kind of interacting nature of the drug epidemic, mostly the opioid epidemic, and the public health crisis that is COVID-19. And a lot of these have to do with access to naloxone, which is also known as Narcan, an opioid overdose reversal drug. And so I wanted to bring you in to explore what happens to a public health crisis when it meets another one. And so to start us off, could you kind of fill us in on how drugs are technology? Because I don't think a lot of people think of either psychoactive or therapeutic drugs as technologies.
So a lot of my work has actually been trying to make that argument that drugs, but whether they are pharmaceutical or what we think of as licit or legal drugs, or whether they are illegal drugs, the kinds of drugs that I've studied most of my career, the fact is that these molecules are molecules, but they're social things. And they are very much shaped by the legal, social, and economic regimes that constrain and enable them to reach their consumers. And so we have evolved very complex regulatory systems for drugs that are both legal and illegal. And in the case of opioids, which are the class of drugs that I've written about most in my career, there's a convergence. These are very similar molecules, if not exactly the same molecule, but they are used within really different social circumstances. And so in thinking of drugs as technologies, I have been at pains to stress the social situation within which these technologies are used is going to even shape their effects on individuals and on collectivities. And so as a technology, you would think about a different set of conditions that pertain to how and when and where and why and who uses a particular drug. In other words, we think of them a little bit more as things that we can follow through the paths they take through our society.
Wow, and that sounds a lot, the social situatedness, like the social determinancy of addiction, which is a topic that I've become familiar with, trying to kind of understand the intersection of these two public health crises. And I was wondering if you could just provide a brief historical outline of the crisis and how drugs like naloxone were developed and how they interact with kind of the overarching problem of the COVID-19 pandemic, which is, at least in the US, bad health infrastructure.
Right, so that's a pretty tall order, but it involves, in fact, a social movement that came about in the midst of other drug epidemics and other infectious disease epidemics. The harm reduction movement is one that I write a lot about in the book, and of course it evolved in complex response to both hepatitis C and HIV, and most notably HIV. And so that movement, which was first of all, presented a historian with a lot of difficulty because whenever you try to tell a story about where and when and how things happen, you have multiple origin stories and origin myths even. And so with this movement, there were many places, many people who were involved in the very beginning of, some people would start the narrative with thinking about needle exchange. Other people would begin to talk about when and where they were when they first realized that antiretrovirals were making it possible to survive HIV, and so their friends were overdosing and dying of overdose rather than of HIV. And so this moment when the opioid overdose, I often hesitate, Bucky, to call it an epidemic because epidemic carries a form of epidemiological reasoning that I think is really dangerous to apply to everything, because drug crises are local, and they typically arise in really material, really socially situated, grounded kinds of ways. And yet we talk about them as if they are national or statewide. And we talk about states that have a high overdose death rate or a low overdose death rate. We talk about countries' overdose death rate. The CDC has been following the opioid overdose death crisis. And I say overdose death simply because I want to make the point to viewers that people overdose all the time and don't die. And in fact, when someone dies of an overdose, it's typically the 9th or 10th overdose that they've had in their lives. And people also witness overdose deaths and overdoses that don't lead to death. And so it's important to understand that overdose is a preventable form of death. And so the movement that I was interested in following, the harm reduction movement, as it kind of later came to be called, was happening simultaneously in proto ways in lots of different places. And so the trick was to tell a story about how that movement discovered naloxone. Now let's talk about naloxone for just a second as a thing. We are approaching the 50th anniversary of the FDA approval of naloxone for opioid overdose reversal. And so this is an old drug. It's a drug that's been around for a very long time, and it's a drug that was enclaved. In other words, it was held within the medical enclave. It's used all the time. Anesthesiologists use it every day in the operating room. It's widely used now, although only gradually so, in emergency medicine. And so because emergency medicine is a relatively recent thing, right, it's celebrating maybe its 60th anniversary. And so these things that seem to us so much a part of our everyday lives really depend strongly upon the social context within which they are situated. Naloxone is no exception. Naloxone, in other words, was not thought of by drug users or harm reductionists or social policy makers or public health officials as a tool for managing overdose until very recently, and only because of this social movement did anyone get the idea that, we should give naloxone out to people who might potentially be able to use it to save a life. And so that movement, which starts in the 1990s and which really doesn't coalesce until the early 2000s, grows up in a lot of ways with the opioid overdose death epidemic that we have gone through in this country and in almost no other, but certainly in the UK, and particularly in Scotland, which was the only nation in the world to have a national naloxone program. And so those kinds of moments are really interesting to me because we have a technology, we have it on hand, we know it exists, we know what it does, we approve it to do that, and yet we don't really make the leap that it took a social movement really to make. I'm very interested in the ways in which the predecessor of naloxone, a drug called nalorphine, which also worked successfully to reverse opioid overdose, but which had some extraneous effects, and dysphoria was one of them, was employed for very different purposes in the United States, where police were using nalorphine, which was called Naline by Merck, which marketed it. That police would use it, they would inject it into people who they suspected of being opioid users, or what they would have called addicts, and they watched the pupillary response of the person as an as an identifier, as a marker. And so that drug was used in a very different way. And that drug, by the way, was still in use in the 1970s. Naloxone did not entirely displace nalorphine in the OR, in the ER, for quite a long time. So I was interested in telling a technology story, a story of the way in which one technology displaces another, and also a story of the way in which people decide, oh, we're going to use this thing differently. An enormous amount of remodeling of social policy, of law, had to be done in order for naloxone to now be distributed in the ways that it is in communities throughout the 50 states.
Wow, that's a fascinating history. And, you know, it's so interesting to me that it was this technology that we knew we had, we knew it worked, we knew it performed a very specific and useful goal, and then it didn't work. And your book and your work tracks these social movements, now they affect them. And I was wondering what kind of approaches in the history of science and technology are important to you broadly for kind of piecing through that story, that historical narrative, and how these social movements did this.
Well, one of the answers to that question, probably everyone out there has already heard. Every other sentence, I think, I use some version of situated knowledge as Donna Haraway's concept of the idea that all knowledge is situated knowledge, and that is very concrete within my book. And even though the book doesn't perhaps cite Donna Haraway as much as it might, it's really a book that was born out of situated knowledges, because one of the things that we've learned in the other concept, a big concept for me, has been undone science. In the undone science of overdose, and I associate that concept with my former colleague David Hess, the undone science of overdose was really interesting to me, that overdose was a phenomenon of which people were dying, but it was not studied. It was understudied. And so I asked a lot of questions in the book about where and when and for whom does overdose come to matter, and who is bringing it, in a sense, to the attention of government, of public health, and of people themselves. And I was very interested in those few scientists who did study overdose, and one of them was very interested in the idea that people don't often overdose when they use a drug that they're used to using in a familiar setting. They tend to overdose and get into overdose is a respiratory problem. I know we're all thinking a lot about breathing right now, but I always think a lot about breathing because opioid overdose essentially works through respiratory distress or duress. And so I was very interested in this idea that if someone did the same dose, the same drug, in an unfamiliar place, they were far more likely to die than if they had that dose in a familiar setting. And I began to think a lot about the recovery mantra of the importance of people, places, and things. And I began to see how scientific knowledge on overdose was inaccurate or distorted if it did not take social context into account. And by social context, I also mean the legality and the economics of the markets that have sprung up around these kinds of drugs. So I was very interested in how people obtain and use and consume, and the meaning with which they freight opioid drugs, because I think that's a really important part of the picture that tends to get forgotten. We tend to kind of discount the symbolic value and the meaning, the cultural meaning with which people associate these drugs. And I think that's actually a mistake. I think it's an important part of the science itself. And as somebody from science studies, from science and technology studies, I am really interested in how scientists and clinicians might go about understanding and utilizing social context in order to understand the phenomenon that they're actually trying to look at. Because I think they miss the phenomenon if they try to study it within laboratories or hospitals. It's just not the same as it is in situ.
It reminds me of Anna Singh's work on unruly edges on mushrooms and their inability to be studied and domesticated in an interesting way. And that's such an interesting point about missing the phenomena. So to close this out, and thank you so much for this really in-depth conversation, I want to ask you, I started the discussion with this kind of idea that the COVID-19 and the opioid crisis could be related, could perhaps magnify each other, and have many overlapping problems. And I want to ask you, what's the important takeaway for lessons of access that we can learn from naloxone and the work you've done from social movements, and can we mix that with insights about our own present moment for good, for bettering the world?
Yeah, that's a really interesting question. And of course, I've been thinking a lot about what's the relationship between these two epidemic constructs and the frames with which we respond to them. And obviously, all of our routines are disrupted, and everything is, in a sense, unfamiliar in our world. And I do worry. As you know, I'm a good worrier. I try to worry from data, but I worry that overdose, although many people somehow seem to think it's this other epidemic that was happening before COVID-19, and maybe it's over, but it's not over. And in fact, I have a feeling there are deaths. The people who track overdose deaths always have a time lag problem, and they always have difficult knowledge questions to figure out. Those are going to be compounded ever so much. I mean, in my own county, there was a week where more people were dying of opioid overdose than were dying of COVID-19. And part of that is that social distancing means that the kinds of mutual aid and harm reduction infrastructures that we have put into place, we can't really exercise. And so I do worry quite a bit about a very terrible convergence between those two epidemic constructs. And I also think a lot about, and the book actually concludes with a plea for considering harm reduction infrastructure and considering how we could infuse the tenets of harm reduction, the philosophy of harm reduction, and the very concrete and pragmatic things that harm reduction means into our healthcare system. But I do wonder, because now we are all thinking a lot about harm reduction, and it seems to me like we need our harm reduction, our very articulate activists and harm reduction spokespeople we need to listen to what they're saying about the ways in which within all of our lives we can minimize harm. We have many harm reduction regimes out there. Okay, seatbelts, helmets, and every time, whenever those were instantiated and brought into being, there was protest. People thought it was an infringement upon their freedoms to ride around without a helmet or to not wear a seatbelt while driving or in a car. And so harm reduction is always going to have that public healthy, kind of convergence. But the harm reduction activists who I looked at, you would never look at them and say, hey, they're staid public health, sort of button down public health people. I mean, they're people who are saying, let's look how people live. Let's look at how they take pleasure. Let's look at what people make of the lives that they have within their current social and economic conditions. Let's look, at the very basic ground level at what people need, what they actually need in their lives to stay alive. Naloxone became a need, and in a way, harm reduction narrowed to the point of naloxone. But harm reduction is ever so much bigger than naloxone. Naloxone alone cannot solve our opioid overdose crisis, and a mask alone cannot solve COVID-19. We have to evolve social infrastructures for responding to these kinds of epidemics. And I think that's what we're in the process of doing, and hopefully we will do it well, and we'll listen to our harm reduction activist friends who have a lot to say about how we could do better. Thanks for the opportunity to tell a story on Technology Story.
Of course.
It's a great website. I hope people will check out the other interviews, and thank you for including mine.